This is a disease presentation on multiple sclerosis, and I am Annie Bowles, and I will be the presenter. So to start with a little bit of background on multiple sclerosis, myelin is a substance that covers the axons in our neurons, in our central nervous system, and this allows action potentials to move much faster along the axon than in unmyelinated axons, as you can see in this figure on the left. This is important in humans and other organisms to quickly transport information from the brain to the rest of the body. In MS, the immune system attacks the myelin that covers the nerve fibers and causes communication problems between your brain and the rest of your body. Eventually, the disease can cause the nerves themselves to deteriorate or become permanently damaged. This affects most, if not all, of the systems of the body, and I'm really interested in this disease because we still don't know why it develops. Multiple sclerosis is known by a couple of terms. It is abbreviated as MS and can also be called disseminated sclerosis. The etiology is currently unknown, but likely results from complex interactions between environmental and genetic factors, which lead to an aberrant immune response and damage to the myelin sheath and neurons. A number of factors appear to influence the risk of MS. The strongest known genetic factor affecting MS susceptibility is not essential for the development of MS, as it only increases the risk by 2 to 4-fold and is present in approximately 20 to 30% of healthy individuals. So that tells us we have quite a lot to learn still about the genetic factors that influence susceptibility to MS. MS affects approximately 400,000 people in the United States and 2.5 million people worldwide. More than 200 people are diagnosed with MS each week in the United States. It typically begins between the ages of 20 and 40 years and is the leading cause of non-traumatic disability in young adults. Initial symptoms rarely occur before the age of 10 years or after the age of 60 years. Women are affected approximately twice as often as men, except in individuals with the primary progressive form of the disease where there is no genetic or no gender preference. Most patients with MS initially experience relapses with complete or near complete recovery interspersed with periods of clinical remission. Although some patients have only minimal symptoms, the majority ultimately develop disability over time as a result of incomplete recovery from relapses or conversion to a progressive phase of the disease. However, it is an extremely variable illness, and the course of the disease is essentially impossible to predict for an individual patient. The symptoms vary widely, and that is part of the reason why it is essentially impossible to predict the course of the disease. They include numbness or weakness in the limbs, and this typically occurs on one side of the body at a time or in the legs and trunk. Partial or complete loss of vision, usually in one eye at a time and often with pain during eye movement. Prolonged double vision, tingling or pain in parts of your body, electric shock sensations that occur with certain neck movements, especially bending the neck forward, tremor, lack of coordination or unsteady gait, slurred speech, fatigue, dizziness, and problems with bowel and bladder function. Lab tests are necessary to diagnose multiple sclerosis. Blood tests are done to rule out other diseases, and then they move to a lumbar puncture, which will show abnormalities in antibodies associated with MS. An MRI is done to reveal lesions on the brain or spinal cord, and evoked potential tests will record electrical signals produced by the nervous system in response to stimuli. Diagnosis of MS is simple in patients with relapsing, remitting MS. It can be confirmed with an MRI and is more difficult with people with the progressive disease or unusual symptoms. This can be confirmed with spinal fluid analysis, evoked potentials, and additional imaging. Some differential diagnoses include spinal cord neoplasms. The neoplasms can be confirmed by the presence of cysts and hemorrhage on imaging studies of the spinal cord. Acute disseminated encephalomyelitis is a post-infectious or post-vaccination autoimmune attack on the central nervous system, but this condition usually responds to steroid therapy. And then, I'm not quite sure how to pronounce this, but Schilder disease is demyelination in teens and children, and some of these patients respond to steroid therapy and immunosuppressive therapy. There is currently no cure for multiple sclerosis, and treatments focus on speeding the recovery from symptom attacks, managing symptoms, and slowing disease progression. But some patients have such mild symptoms that no treatment is necessary. Some complications that can result with MS include muscle stiffness and spasms, paralysis, which typically occurs in the legs, mental changes such as forgetfulness and mood swings, depression, and epilepsy. The prognosis for multiple sclerosis, it is seldom fatal and shortens life expectancy by a few months. So clinical concerns are currently focused on the quality of life. As many as a third of patients have no persistent disability and only intermittent episodes of symptoms. Current research efforts are being focused on treatments which prevent the formation of new multiple sclerosis lesions. These are being tested in phase 3 clinical trials and include the drug that I did my drug discussion on, if you would like to look back at that for more information. Drugs that protect myelin cells from damage or help them recover after attack are another focus for treatments. Another idea that is being explored is destroying the immune system with chemotherapy and then replacing it with some stem cells from the patient's blood to reset the immune system so that it no longer attacks the brain. Another therapy is focused on helping oligodendrocytes to produce new myelin in order to strengthen or repair the damaged cells of the brain and spinal cord. Efforts are also being made to develop new imaging tools to help in the initial diagnosis of MS. Researchers are also trying to identify biomarkers which could help clinicians determine how a patient will respond to a particular therapy. And then geneticists are researching genes that are associated with an increased risk of MS. Some of the informatics applications and issues, one of the big ones is building an application to help identify patients that have a possibility of MS. This can be challenging when the symptoms are so variable depending on the patient and the development of the stage of the disease. There have also been studies done in the VA to help patients both in and out of the clinic, since this is a chronic illness and patients need to be able to regulate their own care in a lot of the time, since their symptoms are so sporadic. There needs to be applications for them to use when they can't get to the clinic necessarily. One thing that I thought was really interesting and recent is the consortium of multiple sclerosis centers has developed a multiple sclerosis registry and database of clinical records and patient-centered outcomes. It collects both clinician and patient-reported data. The physicians will report neuroimaging, genetic markers, clinical and cognitive assessments, and specimen collection and testing for the study. And this is to try and validate biomarkers of the disease progression. And then the patients will report outcomes focused on the challenges of MS and its impact on daily life that will complement the clinician information. These are aimed to increase the understanding of MS and improve care on every level, which I think ties back into what the VA was trying to do in 2006 with their management support systems for patients in and out of the clinic. Here are my references. If you have any other questions, please let me know. And I would like to thank all of you for listening.